Right, we'll get started, Mr. Gouda, if that's okay.
Yeah, absolutely. Yeah, go ahead.
That's fine. So good evening, everybody. My name is Daniel Field. I'm the academic lead for the Yorkshire Foundation Surgical Society and one of the AFPs in Hull. So everyone's joining now, obviously. Super cool. So for those who are not aware, the Yorkshire FTSS is a society catering primarily to foundation doctors to provide resources, talks and content related to surgery and a career in surgery. We have a number of exciting events on the horizon, including an Art of Assisting Surgical Skills course. So for details of how to sign up to our mailing list and how to get involved, if you see the end of this presentation. There'll be also a link at the end to feedback for this session at the end. If you could fill this in, our speaker would be very grateful. So it's my great pleasure to welcome you to our fourth part of our Surgical Specialty Series. And we're very lucky today to have a very experienced speaker talk about his experiences in upper GI and HPB surgery. So Mr. Mohammed Gouda is currently an ST7 working at St James's Hospital in Leeds in the surgical upper GI oncology unit. So he graduated from Leicester Medical School and began his surgical training in Yorkshire. He initially secured a place and began training in cardiothoracic surgery, but ultimately decided that general surgery and upper GI surgery was the path for him. He's currently completing his higher surgical training in Yorkshire and has spent 24 months in high volume surgical oncological units at Hull and in Leeds, primarily undergoing upper GI and pancreatic resections. He's recently just passed his Part A of the FRCS and is due to take Part B this May. He's had extensive involvement and has a passion for teaching both junior doctors and medical students, having strong ties with the University of Leeds Medical School. He's also a laparoscopic skills tutor at the Royal College of Surgeons of England. He's an advocate for his profession and will be telling us about his experiences and his passion for upper GI surgery, with a couple of elements of HPB surgery as well. If you have any questions during the presentation, if you put them in the chat function box, we'll be having a Q&A session at the end. So it's my great pleasure to hand you over to Mr. Gouda.
Thanks, Dan. Thank you very much for that. Right, so let's get starting, really. The average week of an upper GI surgical trainee. Just it's worth mentioning at the beginning, really, that upper GI surgery constitutes half of the work, really. The other half is contributed towards emergency surgery, which is still, an essential part of what makes a surgeon. But it's relevant for people to be aware that there's still, throughout your training, a significant contribution to emergency surgery, and we'll come on to the relevance of that later on. But if we just focus on the elective work, so we specifically want to look at what upper GI surgery sort of has to offer. So on an elective week, it's quite varied. You have clinics, and clinics can be pretty varied as well. You could be seeing bariatric patients, you could be seeing new referrals from primary care with patients with intractable reflux or symptomatic hiatus hernias, etc., or just gallstone disease and symptomatic hernias. So there's that workload that you see in clinics, or you could be following patients having had major cancer surgery. Also, you prioritize the care for inpatients on a daily basis. Usually, some patients would at least require twice daily review if they've had major surgery, particularly in recent days. We have a weekly grand round. We have MDTs active in cancer weekly and bariatric MDT. Theatre for an average trainee in upper GI surgery probably has 1 to 2 lists per week, and that may even include day surgeries. So although quite a busy week, the theatre contribution actually is probably around the 1 to 2 lists a week, and also endoscopy. The components of upper GI surgery can be split really into four components. Benign OG, which primarily involves cholecystectomy work, so gallbladder surgery, anti-reflux surgery, and hiatal hernia surgery. And that section alone, actually, some surgeons, their workload would entail in that kind of work. So cholecystectomy work, fundoplications, and laparoscopic hiatal hernia surgery. There's enough work in that area alone for consultants to be occupied with. Also, there's bariatric surgery, which is multidisciplinary in its approach, and often that requires further specialist training beyond CCT if someone wants to perform bariatric surgery, particularly in a high volume unit or with a subspeciality interest. Esophagegastric cancer surgery is probably the third component, and often that also, particularly in this day and age, requires additional training beyond higher surgical training in the form of a fellowship, and that's probably recognised as almost a necessity in most cases. And OG emergency care. So an upper GI surgeon would often take care of upper GI emergency scenarios such as incarcerated hiatal hernia, esophageal perforation, but also cholecystectomy work. Acute cholecystectomy surgery is a big component of what an upper GI surgeon would contribute in sort of an acute emergency care setting. Challenges of training that I probably would describe, first of all, if one has an interest in esophagegastric cancer, is that it is a relatively low volume cancer if you compare to, say, colorectal cancer or breast cancer. These are much higher volume cancers, and therefore this has been something that I recognise as being a challenge to get all the exposure and experience that's required for you to equip yourself with the skills. But it has helped that over the years, OG cancer has become centralised across the UK, and that to optimise volume and improve outcomes. So in Yorkshire, there's only 4 units really that offer esophagegastric resection. That's Hull, Sheffield, Leeds, and Bradford, and that's a very, very large geographical area. So 4 may seem a lot, but it's not really considering the size of the area. But that's because the number of patients that go on to have resection with OG cancers is not very high in numbers. But as I said, it has helped that there's been some centralisation, which means that when you're in one of these 4 units, you do see a good degree of activity. This is also, I think, reflected in bariatric surgery. So the volume of bariatric surgery is equally variable in the NHS. So you hear about units such as Sunderland that are very, very active with the volume of bariatric surgery they do in the NHS. But I think in Yorkshire, it's not always the case that you'll find an individual high volume unit, and that's probably the reason why if someone develops an interest in bariatric surgery, they probably would need to do a fellowship, be it 6 months or 12 months after their CCT, to sort of get the adequate skills to perform the surgery safely. Another issue that I think that will be a challenge, it's not an issue, but just a challenge, is the late adoption of robotic surgery in upper GI surgery. I say in OG cancer, it could be adopted in other areas such as hiatal hernia surgery or complex incisional hernia. And I think that may be a significant impact on registrar training in the coming years, because the consultants that begin to learn to do robotics, it will take time, and that may take away some of the opportunity for the registrars. Really, that's the one area I predict to be a challenge, at least. And also, I think there's such a wide set of skills that you want to equip yourself with in upper GI surgery that it can feel like it's a challenge in getting all the skills in a limited time of training, actually, because although it's from ST3 to ST8, 6 years, you know, if you take my training, for example, I only started doing upper GI surgery from ST5, so ST3 and 4 had no upper GI surgery exposure. So it's only the latter half of my training that I've had upper GI surgery. But if you factor in the 50% of emergency surgery, etc., you realise that actually it's not a lot of time. So these are what I consider to be the challenges of specific upper GI surgery training. But there's lots and lots of positives of upper GI surgery and lots of reasons why I love it. Number one is you very often see dramatic patient satisfaction with the results of the surgery that's performed, really. And the recent example from that I can recall is a surgery of achalasia, really. I mean, some patients who have achalasia have been suffering for years, and because they can be quite difficult to diagnose and take quite a while to get a diagnosis or even be referred in the first place, these patients are often suffered and not being able to enjoy the food and drink that we take for granted. And you perform surgery where patients are in hospital for one night, and there's a significant improvement in their quality of life, and that applies also to even gallbladder surgery. If someone is symptomatic with gallstones, or they've got a bad bout of cholecystitis, intractable reflux, patients who are selected correctly for reflux can have quite dramatic results. And it's always great when you have a follow-up clinic and you see a patient who's had fundoplication, and they report that their lives have been completely transformed and they're no longer taking their lansoprazole, and it really gives good. You see the purpose of the surgery that's been taking place. And also, I think the same applies with bariatric surgery. You can get quite dramatic results with bariatric surgery, patients' lives being transformed, and people who have not been able to work for years because of poor mobility are able to go out and look for a job and interact in society, or gain confidence, and be happy with their body image. I mean, it can have quite very, very good results, and it's really satisfying to see that in patients. Something else that I consider to be really great in upper GI surgery is the perioperative care in major surgeries. So esophagectomies and gastrectomies, these patients essentially have had quite big surgery, and I like that you sort of see them post-op and try and optimize their physiology, and you apply the physiology that you know about to sort of optimize the patient's state. So you think about how to optimize. You've got a new anastomosis in the chest, and you want to optimize it, blood flow to that anastomosis, and how to optimize the hemodynamical status and all the rest of these markers. And you sort of, it's very good because you're applying the thinking. And the example of esophagectomy is that it is quite physiologically disruptive surgery. It involves thoracic component, abdominal component, often long operations, and you have an objective of trying to make sure the physiological parameters are as optimum as possible, and as surgeons, we are equally involved in trying to guide that with the intensive care team and the anaesthetic team. So I really like that aspect of it. I find that upper GI surgery can be diagnostically challenging, and that is, I think, a good thing, because it means that we have to think about the cases that come through the door, say in a clinic setting. And I could go back to the example of achalasia. These patients often have subtle symptoms for such a long time, which is why their diagnosis can take quite a while to come to light. And I think the dyspepsia, the reflux, the dysphagia, these symptoms can be actually quite challenging to try and figure out what is functional, maybe, or what is actually going to be a result of underlying anatomical issues. So the same applies with reflux, or sometimes even biliary conditions, gallstone disease. It can be quite good to sort of work through the patient's symptoms and try and marry the symptoms with the results that you have, and come up with a good plan for the patient, really. The varied anatomy that you get to have with esophageal surgery, so the added component of the thoracic anatomy, you have to, as well as you have to know your chest anatomy quite well, as well as the abdominal anatomy. And that adds a really good dimension, I think, to OG surgery. And I think we all really enjoyed working on sort of the anatomical structures in the chest, and quite delicate structures you got to work around. Understanding and adapting to changing OG pathology. I think this is something I find interesting, and that's the nature of upper GI cancer has actually changed over the last 15-20 years. Example of back in the day, I think the majority of gastric cancers were distal gastric cancers, probably due to H. pylori. But as we've become better at eradicating that, I think we're seeing less of that and more of the more challenging proximal cancers, proximal in the stomach, and cancers around the gastroesophageal junction. And this is sort of becoming the dominant pathology in OG cancer. And it presents a unique challenge, because basically the spread that you get is both in the chest and in the abdomen. So it's quite a unique cancer in where it is location wise, and the challenge it presents from sort of trying to get control and of the disease. The other thing is that esophageal cancer doesn't have a great outcome. There have been some improvements, obviously, with better neoadjuvant treatment and better surgery, but the outcomes are probably just still not as good as, say, take for example, colorectal cancer. So I think this also is unfortunate, but it is a positive challenge, so something to want to work on and want to improve with the team, with the different teams involved, working with the oncologists, etc., to try and improve these outcomes. The other thing that I really enjoyed and recognized in OG is that there's still so many different ways of doing a procedure. And I recognised that when I came to Leeds, and that there's different philosophies and different approaches, and techniques for doing, for example, in a esophagectomy, there's different levels of radicality, different approaches, minimal access. You can have complete open esophagectomy, you can have a hybrid, you can have completely minimally invasive, you can have, most people have an anastomosis in the chest, but some units routinely do the anastomosis in the neck. The anastomosis can be done hand sewn or end to side, side to side, many different ways that you still see all the variety. And I think it's great that you see all the different ways that things can be done, and you try and think, oh, I like how that's done, and I like that approach, and I like that level of radicality, or that minimal access way, etc. So the variety that you see in OG, I think is fantastic. And you'll go to different units and see, you'll go to a different unit and you'll see a completely different way of doing something compared to a previous unit. So it's good to see this, I think, and I think it just adds to the interest. It adds to the positive. Another major positive for me really is just makes it more interesting and more challenging, and still, I think we're still trying to figure out the best way maybe of how to do it. Is maybe why there's still different ways of doing this kind of surgery. MDT, when we go to MDT, we still find that cases can be challenging to make decisions on, and very senior consultants can still be engaged in what the best approach is for some of the cancer cases. You know, you can't apply a protocol, I think, to a lot of things in OG surgery, and I like that. You can sort of try and individualize the decision making based on the patient's circumstances, or tumor location, or stage, or histology, etc. So you know, I always enjoy going to the MDT and seeing how the decisions are made. It's exciting with the evolving surgical oncology. There's molecular genetics coming into OG cancer, which will hopefully try and improve the patient's outcomes. The example of that is with immunotherapy that may, you know, often now it's used in the palliative setting, but potentially may come in the neoadjuvant, in a neoadjuvant sense, that and I think it's an exciting area, and will hopefully help improve the outcomes for OG cancers. I enjoy interpreting the radiology. We need to look at our CT scans before we perform cancer surgery on the stomach or esophagus. You need to have actually reasonable understanding of the anatomy, the arterial anatomy, and what variations you can get, etc. You need to be able to interpret GI physiology tests, and these are all great things, really, that extra skill that you need to adopt, and I enjoy actually doing, and it's great to sort of look at a CT scan and then go to theatre and see whether you've picked up on the varied anatomy that you may have seen in the arterial blood supply, and whether that can be applied in your approach to the surgery. The negatives, I think, with OG, I think it can be disheartening that you know, seeing patients go through quite strong chemotherapy and big long operations, and eventually, you know, six months later they've got a big metastasis on the liver. that can be quite disheartening, that the cancer biology of OG cancers is still a bad cancer to have, and it can sort of put you off a bit if you feel like there's a lot of effort that gets put in for these patients, but actually, you know, it's often doesn't seem to have much benefit. But you'll of course forget that there are good positive stories as well, and people making great progress and living for several years due to the success of the chemotherapy and the surgery. I think there's going to be challenges with introducing robotic surgery training-wise, but I think this will be a slow process anyway. You can get frustrated with the pace of training in OG surgery because of it being reasonably low volume. And also complications can be significant in OG cancer. So an anastomotic leak in the chest can be quite dramatic. But fortunately, you know, these aren't common either. So but it can add to the stress level perhaps of OG surgery. So why would I tell someone, why would I vouch for upper GI surgery? I think because there's a potential that will make will witness perhaps and contribute to an improvement in outcomes for OG cancer. I think that's a fantastic, you know, that'll be a great success. That, you know, because there's a real great positive impact you can have on patients' quality of life and experience, and it will always keep you stimulated and challenged. I think that's the thing about it, is that you realize that when you do OG, maybe there's always something to learn. So perhaps, you know, people think an Ivy Lewis is the bulk of the work maybe for an upper GI surgery or a gastrectomy, but there are much more unique procedures that take place in upper GI surgery. For example, patients who can't have a stomach used as a conduit for after an esophagectomy. You know, so there's a lot of reconstructive work that takes place in OG surgery. You know, using, for example, perhaps the colon as your conduit rather than the stomach, or maybe not being able to use the normal posterior mediastinum, and you have to go in front of the heart if there's been previous contamination in the back of the mediastinum. There's so many different things that you still need to learn and see, that you know, it feels like there's always something to learn, always something to want to experience in OG, in upper GI surgery. And I think it relies so much on reconstruction that it just leaves the possibilities always very open. So I can give an example that I found very interesting, of a patient who had a sleeve gastrectomy done for weight loss surgery, and therefore a big part of the stomach was removed, and a year or 2 years later the patient developed dysphagia, had an endoscopy, and found to have a cancer at the gastroesophageal junction, presumably due to reflux. And of course he needed to have a good 2/3 of his gullet removed, and a portion of what was left of the stomach removed. So how would you reconstruct this patient? And he needed a colonic interposition, so he needed to use the colon as his new conduit. And and it's so good that there are different options available. You can use jejunum, etc. But this was really great to be involved with, and how the patient was worked up for it. They needed to have their colon checked out with a colonoscopy to make sure that there were no polyps or any sinister lesions before you use it. The patient had the anatomy of the colonic blood supply studied to make sure that a well vascularized conduit was used. There's really potential for great reconstructive surgery in upper GI surgery, and that's really a great element of it, really. And you'll always learn, and it's fantastic from that standpoint. My advice is that it helps to be natural at what you do. I think that I think is something that I believe will allow you to reach great potential, I think. So it's really important that you go and experience a speciality, and you will recognize whether it is your natural home or not. And I think the only way you will know is to explore a speciality. And my example really is that when I was at foundation doctor level, I hated my surgical rotation. Actually, I felt like it didn't give me any real perspective of what the speciality entailed, and I considered things like anaesthetics and even GP. When I did my FY1 surgical rotation, it was only when I went and tried surgery at sort of an SHO level and got to see what the environment was like in theatre, and the kind of work, and get to close skin and use surgical instruments, etc., that you get a feel of this. This is the kind of thing I want. That actually, I feel like this is something that I'll enjoy and want to pursue. So I think you can only really make a decision when you experience it, and I think people should spend time experiencing different specialities, and be it medicine or surgery or anaesthetics, etc. You should, if you feel like you may have an interest in anaesthetics, you should try it. If not, move on. Maybe there's something else you want to try. But I think people, unfortunately, I think they're being pressurized into making decisions too early without experiencing and getting an authentic experience of what it really is. And I think the best way of doing that would be at a foundation level is a taster week, is for you to not be doing ward jobs and etc. and doing discharge letters, but actually have a week where you can spend the whole day with the consultant or registrar, go to MDT, go to theatre, go to clinic, and scrub up, because that will give you the closest idea of feel of the speciality. So that's that. The other thing is to remember that although there are pressures with training in terms of limited time and exposure, I found that I've been very fortunate with the quality of training I've had, and I think if you do seek out good quality training, the volume becomes less important, and quality is always more important than the volume anyway. You need to be able to utilize opportunities maximally rather than minimally and over more time. And I think also passion is really important. You've got to be passionate about upper GI surgery or any specialty that you do, but I think you've got to have a real love for it. There has to be a point where you feel like there's nothing else I want to do. There's nothing else I want to experience, whatever the circumstance, really. So yeah, so I think passion is absolutely crucial, and I think it will allow you to go far. So yeah.
Amazing, thank you, Mr. Gouda. If you just go back to the last slide, Mr. Gouda.
Yeah. That one. Oh.
Yeah, just if you just go on to the last slide for me, sorry, the very, very last slide of yours.
Yeah.
Thank you. So so firstly, I've posted a feedback link in the group chat, and there's also a QR code here. Mo would obviously Mr. Gouda really appreciate any feedback you can provide. If you have any questions which have arisen, if you just pop them in the chat box. We're going to have a bit of a Q&A session now. If you have any burning questions, sort of in terms of specific advice or sort of things related to upper GI and HPB that Mr. Gouda will be able to answer for you, that'll be great. But I'll start with some questions from myself, actually, if I may, Mr. Gouda, just to sort of get the ball rolling. So you mentioned that sort of on an average week you're gonna have about 1 to 2 surgical lists per week, which I think perhaps as a junior doesn't seem like very much time in theatre. Sort of what are your thoughts on that, and sort of how do you balance and enjoy other elements of the week where perhaps theatre is your most preferred sort of part of the week? You know, how do you manage that essentially?
It's a good question. I think, look, as you get sort of towards the end of your surgical training, I think there is less emphasis on, as I said, volume, and actually, so there'd be more specific objectives for you to gain, for example. So at a sort of an earlier stage, you want to get the basic skills set, and therefore you would gain a lot of that in other areas such as emergency surgery. So in emergency surgery, your laparoscopic appendix procedure is sort of would be the basic skill set, and you're doing a lot of that and that sort of develops your initial laparoscopic skills, and that's sort of how it works. So you start broad, and towards the end, the things, the objectives that you have become more precise, and therefore, although 1 or 2 lists doesn't appear quite a lot, it still is probably adequate for your specific objectives at that stage in your training. Do you see what I mean?
Yeah, sure, it makes absolute sense. Yeah,
yeah.
Absolutely.
But in terms of because you sort of you have to, you know, you're not just an upper GI surgeon in the operating sense. You have to understand how the decisions are made, and therefore the MDT side of it, the clinic side of it, the discussion side of it, the post-op care, that's still all complete. That's actually what that's the making of a complete surgeon, really. So it's all equally important, and I don't think people should be sort of panicked too much by the idea of at one stage you may have 1 or 2 lists. I think it's important to remember that the other time isn't wasted per se. It's the other skills that you get, and they are just as important. If you don't know how to look after a patient after some surgery, or if you don't know how to consent a patient correctly, or go through the right decision making for the patient, then the operating itself is very it becomes irrelevant, basically.
Yeah, sure, makes sense. So at the start, when I introduced you, you started a cardiothoracic training program initially, and then obviously moved on to general and then upper GI. Sort of, what was it about cardiothoracics, or so what was your thought process when you moved specialties?
I always wanted to do cardiac surgery at an undergraduate level. So as a medical student, I always wanted to do heart surgery, and I felt like I used to find like the heart anatomy incredible, and it was, to me, the best organ you'd want to work with. And I used to read upon the history of the first heart transplant, etc. And anything related to heart surgery I was very passionate about. So even my special study module, I think we had to select our area, and I chose cardiac surgery, and I did my my elective in the cardiac unit. And so I had to experience it for real, in the real sense. And I went and did a full year at SHO level in the Northwest, and I really enjoyed it, and I gained a lot of skill. But I felt like it wasn't suited for the kind of work I wanted to do. It was too specific, and it was becoming very super specialized. Even with cardiac surgery being super specialized, I was recognizing that there was sort of the aortic valve surgeon, the grafter, the mitral valve surgeon, and I felt like it was too specific. I needed something. I needed to be able to do a case that is challenging, but also have cases which are book standard. But I think in cardiac surgery, I felt like every case that a cardiac surgery surgeon operated on was a massive case, and with limited variation, I think was, again, it didn't feel like my natural home. So although I loved it, and I didn't regret any time doing it, so the skills I gained from my time there was fantastic, and I don't regret a minute of that time spent in cardiac surgery. But I felt towards the end that it wasn't my natural home. It wasn't what I wanted to do for the next 30-40 years, and that's why I went back to general surgery.
Yeah, of course. Yeah. And did you notice there was a change, a sort of difference in culture between cardiothoracic surgery and upper GI surgery, or how would you describe the culture of upper GI surgery? Because there's obviously a stereotype about sort of, especially upper GI surgeons.
What's that stereotype?
But I mean, they're perhaps very particular in terms of what they want. It's like the old boys club kind of thing is often the stereotype.
Cardiac surgery was even more so than that, I tell you. It was, yeah. I mean, I think it's reasonably relaxed in upper GI surgery. It's got, I think it's the right balance of attention to detail and also not over the top. It's not over the top, but I think in cardiac surgery, the room for error in every step of the operation for every operation is very small. So that changes how the kind of it selects out a certain personality and that's a bit less intense in upper GI surgery. I felt like I could enjoy it more. Yeah. Do you see what I mean?
Yeah, of course. Yeah.
I have a lot of respect and appreciation for what cardiac surgeons do, but I feel like I'm able to sort of enjoy upper GI surgery more, and it's, I think, suited more for me in that sense. Yeah. But I think the example, what's good here is that I would never have known that without going and experiencing it. And I think perhaps maybe if I'd never went to experience cardiac surgery, I would have always felt in my life, oh, what if I enjoyed that more? Yeah. So nothing beats a real life experience. And yeah.
And can you just take us through just very briefly about the training pathway in upper GI, specifically in terms of someone who may not be sort of very familiar with how surgical training works?
Yeah, so I think ST3 and 4 are quite generic surgical years. So I didn't do any upper GI in my first 2 years. So the first 2 years, I think, entails 6 months of some either breast or endocrine surgery. And this is how it works in Yorkshire. A year of colorectal, and 6 months is supposed to be of upper GI surgery, but I had another 6 months of colorectal surgery. So the first 2 years are quite generic, and then actually the first 3 years, I think it's beyond the third year that you have to then begin to select the subspeciality that you want to do. So you may have only had at that point 6 months of upper GI exposure, but then you begin to actually select the speciality you want to do. So in that case, if you choose upper GI surgery, the latter half of your ST6, 7, and 8 are spent in that speciality. But if upper GI surgery, it is advantageous to spend some time with pancreas surgery. The anatomy in that supracolic compartment is relevant, and you should be familiar with dissection in that area. So spending time with a pancreas surgeon is greatly beneficial. You in that period of time also, you want to have exposure to resectional surgery. So you'd want to work in a cancer unit for at least 1 year. I think if you want to do upper GI surgery, it's you may, even though the majority of people won't go on to do resectional work, it's still highly advantageous for someone who becomes an upper GI surgeon to have that experience.
Yes, absolutely. And just moving on, just following on from your mention of pancreas, then I obviously know you've gone down the upper GI route, of course, but I understand that you were involved with resections, pancreatic resections, during your training. Sort of when does the branching off to become more specialised in HPB happen, and sort of why did you decide to go down the upper GI route rather than the HPB route?
I mean, I've never really been HPB inclined, but I think the example. So I was very fortunate because I think in Hull, when I was in Hull, you have the opportunity to work alongside the pancreas surgeons as an upper GI trainee. They work together in the same sort of department. So that's why I was fortunate enough to get the exposure in pancreas surgery, and I really thoroughly enjoyed being involved with many Whipple's procedures and distal pancreatectomies and splenectomies, etc. So I think that HPV is different, you know. But if I just take the example of pancreas surgery, from my limited experience doing it then as a trainee, is a fantastic speciality where there's a lot of similar elements in that it is diagnostically challenging, and surgically also it's a very challenging area. There's very narrow margins of error in pancreas surgery. So you operate very closely, for example, to the portal vein, and if you have uncontrollable bleeding from portal vein, you can bleed huge volumes in very short periods of time. So it's delicate surgery. It's very careful surgery because there's a lot of delicate clockwork around the pancreas. So if people are stimulated by challenging surgery, I think pancreas and HPB as a whole is really good. Very interesting anatomy, and also I think they have an exciting future with robotic surgery coming into pancreatic surgery. I think it fits in with the kind of delicate dissection that you see in pancreatic surgery.
Yeah.
That's if again, if someone they think they have an interest in that kind of challenging surgery, they should go and and spend time with a pancreas surgeon and see the kind of surgery they do. And even if it's a long Whipple's case, you know, you should try and see the entire case from start to end to get a real idea of the multiple steps and reconstructive work that they do, and see whether it's something that you'll enjoy.
Absolutely. So we'll be wrapping up fairly soon. So if you have any more questions, please just put them in the chat box. But sort of with some of the procedures you guys do in terms of, you know, 8, 9, 10 hours, you know, esophagectomies, you know, how do you find your work-life balance? You know, how in terms of balancing that, you know, what's your experience with that and your tips and tricks to sort of make sure you have a work-life balance with such a demanding job?
Yeah, you know, honestly, it's interesting. I don't feel like it's demanding, but because I think if you have an 8-hour operation, if you are being trained on the case and you are learning something, it's incredible how quick it flies. You know, so if you're enjoying it, it's not a burden. And the way I look at it is at the end of the day, that's, you know, if I can't really feel sorry for myself if I'm scrubbed for 8 hours. If the patient is suffering with the cancer, you know, like you're doing it for the patient's sake. So, but in terms of how one deals in surgery training as a whole, I think is about having an interest outside of work, be it a sport or if you like to go for nice walks in the countryside, or you have. But the other thing I think is really important is having good friends in surgery. I find having friends who do the similar kind of speciality at your same level of training is a very good thing to have, because you both can sort of you know, it's a form of like psychotherapy, you know, for the stresses of the training program. It's really important that you have people who are in a similar position, because you realize that by having colleagues who work the same hours or adapt to the same work-life balance, it's important to know that there are other people who are on sort of a rota-based system and work that nights and days like yourself. So I think it's just having friends in the surgical environment has helped me really.
Absolutely, yeah, absolutely. So I mean, I'm asked my last question now, and then we'll wrap up. So, it's totally gone from my brain now. Which is sorry, 1 second. Yeah. So my last question would be, so you've obviously talked about sort of recommending sort of foundation doctors getting onto taster weeks, etc. And you've obviously emphasised the fact that, you know, being a foundation doctor isn't quite representative of what it's like to be an upper GI registrar. Do you have any other tips in terms of someone at my stage or foundation training or early core surgical training in terms of to help their portfolio, to get some more exposure? You've obviously mentioned taster week. You know, what other things can people do to try and get onto your upper GI, you know, pathway?
So I think that from what I understand, like, try and develop the surgical skills early. So any opportunity to go to theatre and develop a logbook, I think, is becoming like really important to develop a logbook, even if it involves small steps in any procedure, draining an abscess or. So assuming we're talking here at a foundation doctor level, is that right? Yeah. Yeah. So the first step will, of course, be to secure a core surgical training number. And I think at foundation level, if you can begin early on developing a logbook, if you can, from what I understand, engagement in audit and research, I think that's it's always helps, isn't it, for the CV? But I would say try and develop a surgical logbook early, and try, if any opportunity to go to theatre. If you give any registrar colleagues your sort of contact number for when you're free say if you're in theatre and you want to show me talk me through how to drain an abscess or how to close skin, because I think if you develop the basic skills early, then it's so much more easier for you to move on. Your confidence is transformed at a later, in the early stage of your core training. I think the other thing is also to prepare for exams early. I don't think, I think it's right that you should quickly look into how to begin to settle in membership exams. You shouldn't wait until you get a core training number. It's becoming an issue with people leaving their membership exams late on in their core training. So I still think these are the essential bits of advice, really, is to develop your skills. So in real life, you will come across as more confident, and you will be able to make most of your time if you've got the right basic skills. I mean, if you're not comfortable with closing skin sort of in your first year of an SHO, I think it will work against you, and you're less likely to get more of an operation than if you haven't got the basics right. And also the membership exams, you should start preparing for, even if it's just preparation. Even though you may have come out of medical school, you shouldn't leave a big gap to get back into the process of preparing for exams. So I think they're the best two examples I can give.
Yeah, perfect. Yeah, awesome. Okay, amazing. So I think we'll start wrapping up there. So if you haven't filled in the feedback form with the QR code or the link in the chat, that would be great. The QR code in the middle is the sign up for our mailing list about our future events. Mr. Gouda and I will stay on for the chat for the next 5-10 minutes if there's any sort of other questions people would like to ask. But otherwise, I'll wrap that up and say thank you very much for joining, and thank you for Mr. Gouda for your expertise and your passion about your exciting surgical subject. So thank you.
Thanks a lot. Thank you.